Hi, my name is Dr. Jeff Foster. I'm a GP with a specialist interest in men's health. I've been a doctor for just off 20 years. I have a subspecialty interest in male health, testosterone in men, erectile dysfunction, and I sit on the committee for the British Society of Sexual Medicine. So we write the gold standard treatments for the NHS and privately for testosterone and male health in general. Today, we're going to talk about prostate health because it's something that a lot of us know a little of, but there's a lot of things we can do to try and improve our prostate health and reduce our risk of cancer as we get older. And we should be able to cover that, everything you need really in prostate in about 10 minutes, really. So the first thing is prostates and what is it? So it's not a particularly complicated organ, really. It's a walnut-sized gland, generally, that sits just below your bladder and is responsible for helping function in terms of orgasm, ejaculation, and helps the seminal vesicles, which produce semen, and it runs through them. So it's a sexually active organ. Until puberty, it doesn't really do anything. And as we get older, it becomes more sexually active. And it's important because it's testosterone sensitive, which means that basically throughout your life, as long as you have some testosterone, now it doesn't matter if you have a little bit or a lot, so it's just a binary switch, yes or no, your prostate is going to get bigger. And that's something that we all have to deal with as we age. The important thing about the prostate gland, however, is that the urethra, the tube that we pee out of, runs right through the middle of it, which is particularly annoying because it means that as you age and that prostate gets bigger, of course, the tube is going to get squeezed. And that's part of the problem and why we all think about how our urinary flow changes as we get older. Now, the beauty of the prostate, as I say, is actually relatively simple. There's only really three things that can go wrong with it. So it can get inflamed or infected, and that's prostatitis. And you usually get that from either a sexually transmitted disease or from having a stagnant or a cyst or some sort of blockage, which means that it gets inflamed and infected. Or it can be due to procedures. So if you've had a recent catheter or you've had abdominal surgery or something that affects the anatomy in that area, that can do it. Most blokes know they've got prostatitis because it hurts like hell. They'll pee a lot and it'll hurt. And often the area, the perineum, which is the bit between the end of your scrotum and your backside, that becomes very, very tender, and sitting down can really hurt. You even see prostatitis, interestingly, in a lot of guys that do long distance cycling because the cycle seats are not particularly pleasant to your prostate. So anyway, but all easy to treat. The next thing we see is an enlarged prostate, and this is benign prostatic hypertrophy, which is basically the thing I said on the other slide. That just means your prostate gets bigger as you get older. Virtually all men over the age of 50 have a slightly larger prostate than they did when they were 30, and sadly, there is nothing much you can do about this. It's just the inevitability of getting older, and you often don't notice it until it becomes a problem, and I'll come on to that in a little bit. But the other thing to think about, of course, is prostate cancer. And prostate cancer is actually the most common form of cancer in men, except for prostate cancer. So except for skin cancer, obviously just said prostate cancer, but you know what I mean. So only 1 in 35 men are actually going to die from it. But if you live long enough, every guy will get prostate cancer. So the actual estimate is that if you get a 90-year-old, 99% of all 90-year-olds are going to have prostate cancer cells in their blood, in their body, sorry, not in their blood. But it doesn't mean they're going to die of prostate cancer. Something else will probably get them. But it just means that simply aging means that we're very, very likely to have this problem. You've just got to hope that something else gets you. So in terms of symptoms of prostate disease, as I said, the biggest issue is the fact that the tube, the urethra that we pee out of, runs through the middle of the prostate. So no matter which prostate problem you've got, infection, just largely getting bigger, or it's cancerous, that tube is going to get squeezed. Now, there will be slight variations on how that presents, but the principle is always there. One of the easiest ways to think about benign prostates, the non-cancerous symptoms, are just the fact that as that tube is getting squeezed, your flow is going to decrease over time. So for example, my son's 11 and we were at a restaurant a couple of months ago and we both went to go pee, and he's standing at the urinal and he's peeing, and he's peeing above his own head. His ability to pass urine is just like it's like a fire hose. This thing is out of there, and he's like laughing away, you know, and then you sort of look down and think, God, what's this pitiful dribble that I'm now passing in my mid-40s? And sadly, it's something that you don't really think about consciously, because obviously most blokes are not standing at a public urinals comparing each other's urinary flow. So you don't really think about it until it starts to become a problem. And most guys start to complain when it affects their quality of life. So either they're having to go more frequently than normal, they're not emptying their bladder completely, they might have dribbling afterwards. You can get a bit of stage fright, so hesitancy becomes a problem where you can't relax the muscle. And that means you're having to sort of wait before you can pass. Or the other really common one is just getting up more times at night. Now, it's pretty common for most guys from 40 plus to get up maybe once at night, and that's fine. But if you're getting 3-4 times a night, that's exhausting and it's pretty fatiguing as well. The other thing to think about in terms of prostate cancer, which is often different to a benign large prostate, are the more worrisome signs. So things like blood in your urine, bone or pelvic pain, fevers, temperatures, and those are not markers of a normal healthy prostate that's just got bigger. Those are more worrying, obviously. We get to see those more quickly. In terms of assessing a prostate, well, we classically have the image of you going to see your doctor and the doctor getting a glove on and usually sticking his finger up your backside. And that's the historical image we have of prostate checks. But actually, we don't really rely on that just as much as we used to. And there's lots of other things we can do that are more effective and better at screening for patients with prostate disease. I've put up the picture to give you an idea of what different prostate sizes might be with age. So obviously we talked about a walnut being the optimal size, and that's generally the standard before the age of 35, 40. And afterwards, most guys have a ping pong or golf. But you could imagine if you had a prostate the size of a tennis ball, crikey, you're going to have trouble peeing out of that. So other tests we do look for are a blood test, which is the prostate specific antigen, which is the PSA. We do the rectal exam, of course, which is in some cases required, but actually not as much as you used to. And then imaging, such as an MRI scan and biopsy. And that's quite a new thing, the MRI scan, because it's actually been really effective in reducing the amount of biopsies we used to have to do. I guess the point of this more so is that if the reason you're worried about going to the doctor is that you have to get a rectal exam, there are ways we can get around this for most people. And it shouldn't be a reason to not see your doctor in case you're worried. So it's probably worth us mentioning a discussion around PSAs and prostate cancer, because we've got 40,000 men diagnosed each year with prostate cancer and 10,000 deaths each year, which is actually pretty big numbers. And yet the problem is, of course, as you may have noticed, there is no national screening on the NHS for prostate disease. And that's largely just because the PSA test, the prostate specific antigen, just isn't that good. So the PSA, this prostate specific antigen, is a hormone that's released by your prostate every year. And as I said before, your prostate gets bigger as you get older. So the PSA number is going to go up. The problem is we have a rough idea of what normal should be. So we say any age between 50 and 69, it should be less than 3. We don't know what the level should be above 70 because they're all so random. And the problem is that you can often get false positives and false negatives. So supposing you were somebody that just had a slightly large prostate at an earlier age, well, you might have a PSA that's above 3. You then do your blood test because you've been told to go for screening, and it shows you might have prostate cancer. You then get sent off for further testing, and it never was. But now that we've got this MRI scan ability, we can actually scan people and say, actually, you're okay. The scan was completely normal. You don't need a biopsy. You just got a big prostate. That's fine. And that is okay. And the false positive is actually probably the better of the two outcomes. The worst is that you can get false negatives. Pardon me, up to 15% of people with prostate cancer will have a normal PSA. Now, that's pretty worrying because it means that if you're using a national screening tool and you're going to miss 15% of aggressive cancers, it's not a very good test. And that's the main reason why. So the argument is we're very good at picking up the kitten cancers, the ones that are very slow growing, very gentle, and probably aren't going to kill you off because they show a slow increase in PSA over many years. The tiger cancers, the really aggressive ones that are going to polish you off in 6 months or a year, well, those PSAs stay low. And in many cases, they actually go down because the cancer is so aggressive, it destroys the prostate gland and actually makes the a PSA get a lower result. So of course, if you're just doing this PSA test as a one-off and you've got nothing to compare with, you go to your doc, you don't really have many symptoms yet. You might just have a slight difficulty passing urine or something mild because you're 55 or 60. You have your blood test done, PSA is really low, and you go, great, I'm okay, brilliant. Whereas in actual fact, of course, you've got a really aggressive cancer that's spreading. And that's the reason we don't really use PSA as a national screening tool. Now, that's not to say that a PSA is not useful, but you just have to be aware of the context of what it's for and how often and when we should test it, et cetera, et cetera. And it's something that we just can't do on the NHS yet. Doesn't mean it shouldn't get done, but not on the NHS. So what can you do? Well, I think the problem is that when we talk about prostates and prostate cancer, we spend so much time talking about why PSA is a good or bad test and why we should be thinking more about screening, but we don't spend enough time thinking about, well, how can we stop getting prostate cancer in the first place, which is probably more important. And if we had reduced prostate cancer risk, then the screening is not as important anyway, which is really the key to all this, I guess. In terms of non-cancerous prostates, treatments are actually really, really successful now. And you can take tablets that reduce the size of your prostate, although they're variable. You can take tablets that relax the muscle so you pee better, and they're really good. Surgery has come on leaps and bounds in the last couple of years. And we now offer non-significantly invasive surgical treatments to increase the pathway so you can pee better. And there's things like Urolift, which sort of hoiks the side of the prostate up and keeps it out the way. There's green light lasers and there's steams and all these sort of things. And they sound bizarre, but the beauty of all these is they don't require a scalpel. There's no scalpel, there's no bleeding, there's no stitches. It means patients are in and out in the same day or two. Very minimal complications. They don't bleed, they don't get clots, it's less painful. So really successful stuff. And it is just getting better and better each year. So for non-cancerous treatments, the outcomes are getting really good. If you wanted to try and reduce your risk of getting prostate cancer, well, one of the positive things about prostate cancer is that it's really carcinogen sensitive. So in comparison, for example, testicular cancer, really rare. It's actually like the 100th most common cancer. But if you're going to get it, you're going to get it. And there's nothing you can do to try and reduce the risk. Well, with prostate cancer, it's the exact opposite. It's really common, but lots of the things we do in our lifestyle increase or decrease our risk accordingly. So, for example, smoking, which we know causes lung cancer and heart disease and stuff, actually increases your prostate cancer risk. So just reducing smoking helps. We know that keeping alcohol intake to a minimum reduces your prostate cancer risk. Alcohol's a tricky one, and we often talk about alcohol being a similar process to where we were with smoking maybe 20, 30 years ago. Most of us drink alcohol, and I do, but we know it's not very good for you. And it may be the case that in 50 or 100 years, we look back and go, God, I can't believe those people in 2023 used to drink alcohol. It's so bad for you. And it probably will be the case. But for now, we know that moderate amounts of alcohol is not too detrimental, but high levels of alcohol is certainly not good for your prostate cancer risk. The other big thing we need to do is think about a healthy body weight. And we know that obesity is related to an increased risk of prostate cancer, and in particular, an aggressive form of prostate cancer. So having high estrogen levels, low testosterone, both of those increase your risk of an aggressive form of prostate cancer. Interestingly, there are a few subtle ones. So calcium intake is quite interesting. And we know that men that have very high levels of calcium, but we're talking like cups and cups of milk each day and cheese and stuff like that, have an increased risk. But I think unless effectively you're living off dairy, I wouldn't be particularly worried about it. And there was a very interesting study done, I think in Scandinavia a couple of years ago, and that looked at sexual activity in prostate cancer. And it showed that actually the more sexually active you are, the reduction in risk you have of prostate. So basically more sex is less prostate cancer, which is brilliant. And a lot of patients have asked if I could produce certificates or something they could give to their wives or partners. But joking aside, the study is actually really good. And it seems to be the theory that the prostate, in many other organs in the body, requires regular stimulation and usage to keep the cells healthy. So by being sexually active, it helps reduce abnormal cell turnover. How often you need to be sexually active for wasn't really suggested in the study. And I think they based it around 3 times a week, but I don't think there's an agreement which is the best amount. And the other thing, of course, is no matter what you would like to say or not, your prostate doesn't know or care whether there's a person at the end of your sexual activity or not. So it's just simply the process of being sexually active. And the other thing which I wanted to mention finally, which probably just goes back to that original point, is PSA checks are not useless. They are useful, but we just need to be mindful of the implications of what they mean. So I don't think it's fair to go to your GP every year and say, I want a PSA test, just because I think it'd be useful to have, because the NHS isn't really kitted up for that. And that would push it into an NHS screening program, which is just not funded to do. So by all means, if you have symptoms, you should definitely be getting a PSA test. But if you wanted to get objective data about your PSA, then you'd have to sort of do a private yearly test. And again, it's something we offer our patients, and a lot of companies do. But objective data is everything in medicine these days. And it used to be that you would wait until you have a symptom, and then you go to your doctor and he does a test and you go, well, that shows that. And you go, great, now I try and treat that. But we should try thinking more about preventative health and optimization. And we often don't do that. So I would say objective data around PSAs is really useful. And if, for example, you had a PSA and it was 1.5 every year, 1.5, 1.5, 1.5, and then suddenly it jumps to 2.9 or whatever, something like that, then even if that level is still below 3, then you know something's abnormal for you. And that might be the time to go to your doctor and say, you know what, I think I've got an abnormal result. Now, where do I go with it? Can I have a further test to check? And that might be a useful way to not overburden the NHS, but still give you that objective data that you need to see if a PSA could be useful in monitoring prostate disease. Overall, I think prostate is one of those things that we can do a lot to reduce the risk of. If we try and maintain a healthy lifestyle, we shouldn't need to worry about it too much. And I wouldn't get het up on thinking, I need to monitor my PSAs, I need to monitor my PSAs. It's not that important. It's useful, but it's not the be all and end all. Have a healthy lifestyle, do everything you can to try and maximize that, and then hopefully the rest of it falls into place, because of course it'll have other health benefits for you overall in the long term anyway. And I think that's probably all I wanted to say. Thank you very much.